I have to say, though, when I first saw the title proposed for today, Health System Reform in a Budget Crunch, I didn't think of the 10,000, 5,000 foot ground level thing. I thought of Gabriel Garcia Marquez's novel, Love in a Time of Cholera. We all agree that development of a high-performing healthcare system would produce economic and public health benefits. And in fact, in large measure, we find consensus on what a high-performing healthcare system would be. The difficulty always is moving towards that during whatever our current circumstances are. I've noticed it's become very fashionable in government to speak of spending as investment. We invest in this, we invest in that. It's become almost the constantly used term instead of spending. And I suppose if all spending is investment, then New York has been investing a great deal in health care. As Joe said, we're among the top 3 states in overall per capita spending. Our Medicaid program, you almost have to create a second level on the charts to show how much more we spend. We spend more on graduate medical education than any other state. I think our undergraduate medical education spending puts us in the top 3 per capita. Hospitals are the center of our healthcare system spending. We spend more than other states on hospital care, and in particular on hospital care during the last 6 months of life. Of $100 of healthcare spending in the state, $96 or more goes into acute and long-term care. Now, it's been observed that we're a high per capita GDP state, and therefore our per capita health expenditures as a percentage of GDP are not out of line. That may work or at least mask the problem during a period of rising incomes and prosperity, but I think you only have to take a quick look at the charts that Joe showed to realize that if we're in a downturn, to have that high and rising percentage of spend and at the same time not being controlling that spending while our GDP may be flat or dropping, it's a dead end. It's actually a strategy to become another Michigan, if you take my meaning there. So we're spending a lot on healthcare. The question is this spending wise investment? In fact, is it investment at all? The usual meaning of investment is to hold back from current consumption and then put those resources to work to create a future benefit or future good. We defray current consumption because we want to share in the profit or beneficial results of the investment. Measured against that definition of investment, we've been investing very little in health care. Where are we? Again, look at the statistics that Joe showed. We're just kind of in the middle on most measures of community health status, quality of care. Where we do have a reputation for excellence, it's virtually always in acute, immediate, heroic, high-tech care, not primary care and prevention. Again, classic marks of spending, not investment. And nevertheless, our hospitals have narrow margins, fragile finances, old plants, old equipment. These are all hallmarks of underinvestment. So again, lots of spending in hospitals. It doesn't have the characteristic of wise investment. We're threatened with physician shortages and maldistribution throughout the state. So again, lots of spending on physician training. As an investment, it doesn't look like it's going to have the return. Overall, I would characterize the system then as overspent and underinvested. Another round of ordinary budget making, budget cutting, it would have to be within this current budget paradigm, this current reimbursement paradigm will only reinforce that. We'll do something with spending, we have to do spending, but the question for us is how we can turn that towards the idea of long-term investment and return on investment. I'm going to have Deborah walk you through how that does. I so admire her group of analysts and how they approach it. I've often said the analysis is so crisp and clear that it essentially shows the pathway for policy. It's not that you just get a whole bulk of analysis and then sit down to try to figure out policy. What I'm really intrigued at is the kind of opposition to reform that we get. Again, no one's satisfied with the current system. Almost everyone will agree that we have to reform it and change. And yet there are certain standard arguments that are used about why we can't reform at this time, meaning any given time. The first one is that the reimbursement system is so interconnected that you can't change just one factor without disturbing a myriad of other factors. So you can't just change one thing at once. And then at the same time it said that it's so complex and has so many factors that no one can master all of the factors and change them all at once without producing chaos. And then finally, it's that no matter how logical and fair the reform measure is, until institutions know their own individual bottom line, you can't expect them to commit to the principles of reform. If you accept all three of those, it's a prescription for paralysis, or at best, tiny little incremental changes. In the budget crunch that we're in, the argument then is, well, this is that we need a timeout. Then if we come out of this and we have a period of prosperity, rising per capita GDP, it's why do it now? We're doing just fine, there's money to spend. I am sympathetic with institutions and providers that say that we don't have the cash cushion, the investment capital to make these changes, and we have to accommodate rates of change and phase in change. But I think if you accept that set of arguments, we really will never have reform. So we're very focused this year on breaking through that complexity, rigidity argument and introducing real reform. I've been in front of hospital groups and said this, and I think that they're going to, ride me out of town on a rail. But the fact is, our industry is sufficiently strong to participate in these changes this time around. Between 2005 and 2007, on those 3 years, our New York hospitals booked a total aggregate positive margin, profit if you will, of $4.3 billion. Margins have run between 2.8 and 3% positive. This is a significant improvement over prior years. It's not great by national standards. It's not been a decade of that so that large cash reserves are built, but it isn't an industry on the ropes. Through 2007 and into this year, we completed our Berger implementation process, and this has put many hospitals in a significantly stronger position. They've attracted volume from closed facilities. They have new economies of scale. They should be in stronger negotiating positions against other payers. I look down the river in Kingston-Benedictine combination there. They had tried to merge 10 or 12 times, never accomplished it. We now have merged a single hospital in that community and invested $47 billion of HEAL F-sharp money to get it done. That's just an example of what's happened around the state. Think of what a stronger position healthcare going forward in Schenectady is now that we have a single institution. We've provided them, I think, well in excess of $30 million to get that done. It was a lot of turmoil, but there's now going to be a stronger institution there. We've done that around the state. In Manhattan, there were 2 closed hospitals. I know from personal contacts that the hospitals that benefited from those closures are having the best years they've had in a long time. So we have made that investment. We're ready to make the reform based on the investment that we've made. And putting it off, I think, will simply dissipate those gains and never get this done. So this